Heart disease has occupied a misleading position in public health narratives for decades, framed as predominantly a male concern despite evidence showing cardiovascular disease kills more women than men annually. Women receive fewer preventive screenings, experience longer diagnostic delays, and are less likely to receive aggressive treatment. The reality: heart disease is the leading cause of death for women in the United States, claiming more lives than all forms of cancer combined. Men tend to develop cardiovascular problems earlier. Women experience a different trajectory. Cardiovascular risk remains relatively low through reproductive years, then accelerates sharply during and after menopause when estrogen levels decline. But hormones represent only one component. Genetics, lifestyle factors, pregnancy history, sleep patterns, and chronic stress all contribute to cardiovascular vulnerability. Estrogen functions as a cardiovascular guardian throughout reproductive years, influencing multiple systems that protect heart and blood vessel health. It promotes favorable cholesterol profiles by increasing HDL and decreasing LDL levels. It maintains vascular flexibility by supporting nitric oxide production, keeping blood vessels relaxed and responsive. It reduces inflammation in vessel walls, lowering the likelihood of plaque formation. When estrogen production declines during perimenopause and drops further after menopause, these protective effects diminish or disappear entirely. Cholesterol profiles shift unfavorably, with LDL levels rising and HDL levels falling. Blood vessels become stiffer and less able to dilate in response to increased blood flow demands. Inflammatory markers increase system-wide. Blood pressure often rises. Hot flashes and night sweats, experienced by the majority of menopausal women, correlate with increased cardiovascular disease risk, independent of other factors. The mechanism likely involves vascular dysfunction. The sudden temperature dysregulation reflects underlying problems with how blood vessels constrict and dilate. Depression rates also increase during the menopausal transition, and depression itself is a cardiovascular risk factor through multiple pathways, including reduced adherence to healthy lifestyle behaviors and increased inflammatory signaling. Chronic stress produces measurable physiological changes that directly damage cardiovascular health. When the body perceives threat, whether physical or psychological, it activates the sympathetic nervous system and releases stress hormones, including cortisol and adrenaline. In acute situations, this response is adaptive. The problem emerges when stress becomes chronic rather than episodic. Sustained activation of stress pathways keeps cortisol levels elevated, blood pressure higher than baseline, and inflammatory markers active. Over months and years, this produces cumulative damage. Blood vessels experience constant elevated pressure that damages their inner lining. Inflammation becomes chronic rather than acute, accelerating atherosclerosis development. Stress also influences cardiovascular health through behavioral pathways. People under chronic stress are more likely to smoke, more likely to overeat, particularly high-calorie comfort foods, more likely to skip exercise, and less likely to prioritize sleep. Each of these behaviors independently increases cardiovascular risk, and stress tends to trigger multiple unhealthy behaviors simultaneously. Research has documented that acute psychological stress can precipitate cardiac events in people with underlying coronary disease. Stress triggers changes in blood flow to the heart muscle, increases platelet aggregation, making blood more likely to clot, and can provoke dangerous heart rhythm abnormalities. Family history. Cardiovascular disease clusters in families for reasons that involve both inherited genetic variations and shared environmental factors. If a parent developed heart disease, particularly at a young age, their children face elevated risk. The relationship is dose-dependent. Having multiple affected first-degree relatives increases risk more than having one, and earlier onset in relatives signals higher risk than disease that appears in later decades. Genetic factors influence cardiovascular risk through multiple mechanisms. Some variations affect cholesterol metabolism, causing LDL levels to run high even with healthy diet and exercise. Others influence blood pressure regulation, making hypertension more likely. Some genetic profiles increase inflammatory tendency, accelerating atherosclerosis progression. Family history also captures shared lifestyle patterns that develop within households. Families tend to eat similar diets, maintain similar activity levels, and manage stress in comparable ways. These learned behaviors persist across generations and contribute to cardiovascular risk independent of genetic inheritance. The practical implication of significant family history is that more aggressive preventive strategies are warranted. Someone with a strong family history should begin cardiovascular risk screening earlier, maintain stricter blood pressure and cholesterol targets, and prioritize lifestyle modifications, even in the absence of current symptoms. Pregnancy complications. Pregnancy functions as a natural cardiovascular stress test. Gestational diabetes, preeclampsia, peripartum cardiomyopathy, preterm delivery, and miscarriage all signal increased long-term cardiovascular risk. Women who experience gestational diabetes face substantially elevated risk of developing type 2 diabetes later. Women who had preeclampsia show persistent vascular dysfunction years after delivery, with higher rates of hypertension and earlier coronary artery disease development. These pregnancy complications function as early warning signals, triggering enhanced cardiovascular monitoring. A woman who had preeclampsia decades ago remains at elevated risk today. High cholesterol. Excess LDL cholesterol accumulates in artery walls, initiating atherosclerotic plaque formation. LDL particles penetrate the vessel lining, become oxidized, and trigger inflammation. White blood cells attempt to clear oxidized LDL, but become engorged with cholesterol, forming foam cells that cluster into fatty streaks. Over time, plaque grows, narrowing vessels and restricting blood flow. The most dangerous scenario occurs when plaque ruptures, triggering rapid clot formation that completely occludes the vessel. In coronary arteries, this causes heart attack. The relationship between LDL cholesterol and cardiovascular risk is continuous. Lower is consistently better. When blood pressure remains elevated chronically, constant increased force produces cumulative damage. Vessel walls thicken and stiffen. High blood pressure damages the endothelium, creating sites where LDL cholesterol can penetrate and initiate plaque formation. The combination of hypertension and high cholesterol is particularly dangerous. The heart suffers under sustained high blood pressure. The left ventricle must generate more force to maintain adequate blood flow. Over time, the ventricular muscle thickens. While this initially maintains function, thickened muscle requires more oxygen and is prone to abnormal rhythms. Circadian disruption. Cardiovascular function follows circadian rhythms. Disruption through irregular sleep timing, nighttime light exposure, or schedule misalignment produces measurable consequences. Research found people with high nighttime light exposure show significantly elevated risk of coronary artery disease, heart failure, and stroke. The mechanism involves melatonin suppression, eliminating its cardiovascular protective effects. Sleep timing matters independent of duration. People who are naturally late chronotypes face increased risk when forced to maintain early schedules. The mismatch creates chronic circadian misalignment, affecting blood pressure regulation and glucose metabolism. Reducing cardiovascular risk requires addressing multiple factors simultaneously. Managing blood pressure, controlling cholesterol, maintaining healthy weight, exercising regularly, managing stress, prioritizing sleep, and avoiding tobacco reduces risk substantially. For women approaching menopause, these interventions become particularly important as estrogen's protective effects decline.